Welcome to a complete visual guide to the clinical respiratory examination, a systematic diagnostic blueprint built around spatial assessment, physical first principles, and vignette-based diagnostic reasoning. This is one of the most heavily tested clinical skills across MBBS, USMLE, NEAT-PG, FMGE, MRCP, PLAB, and AMC examinations, precisely because every single physical sign in the system traces back to a learnable mechanical or physiological principle. There is no need to memorize isolated facts when a mechanism explains them instead. Throughout this video, we will move through the chest wall, the rib cage, the bronchial tree, and the carinal angle in a structured spatial sequence, mirroring exactly how a clinician should approach a real patient. By the end, you will understand not just what each finding looks or sounds like, but why it occurs, allowing you to reconstruct any examination finding from first principles rather than relying on rote memory, even under the pressure of an unfamiliar exam vignette. The respiratory examination follows a deliberate spatial journey, moving progressively from the periphery toward the core, and examiners heavily weight this sequential logic when grading clinical performance. The journey begins at the end of the bed, where a macro assessment is performed through simple observation and audition, looking and listening before ever touching the patient. The second stop is the peripheries, focusing specifically on the hands and pulses through inspection and palpation. The third stop is the head and neck, assessing cranial and cervical signs through further inspection and palpation. The fourth and final stop is the chest itself, the core of the examination, assessed through the complete sequence of look, feel, tap, and listen: inspection, palpation, percussion, and auscultation. The single most important teaching point embedded in this framework is this: pathology at the core is often first revealed at the periphery. A subtle finding in the hands or face can point directly toward a serious underlying chest pathology before the stethoscope ever touches the patient, which is exactly why skipping the peripheral examination is one of the most common and costly errors made by candidates under exam pressure. Before approaching the patient at all, a wealth of diagnostic information is available simply from observing at the end of the bed. Habitus and posture offer immediate clues. Cachexia, or significant wasting, raises suspicion for malignancy or advanced COPD, while tripod positioning, leaning forward with hands braced on the knees, classically indicates acute severe asthma or a COPD exacerbation. Orthopnea, the inability to lie flat, points toward heart failure or severe respiratory compromise. Scanning the bedside itself for paraphernalia is equally revealing. Oxygen delivery devices, nebulizers and inhalers, sputum pots, and peak flow meters all offer clues about chronic disease and current severity before a single question is asked. Audible sounds carry their own diagnostic weight. A barking cough suggests croup. Stridor indicates a critical upper airway obstruction demanding urgent attention. An audible wheeze indicates bronchospasm, and a wet cough suggests excess secretions. Perhaps the single most clinically important objective marker at this stage is speech pattern. The inability to complete full sentences without pausing for breath is a critical, heavily weighted marker of respiratory distress severity, frequently used as an objective grading criterion in both real clinical practice and exam scenarios. Examination of the hands yields several of the most consistently tested findings in respiratory medicine. Clubbing is identified by loss of the normal 160-degree angle between the nail and nail bed and is present in cancer, bronchiectasis, idiopathic pulmonary fibrosis, and cystic fibrosis. A critical diagnostic trap to remember: clubbing is absent in simple COPD, so finding it in a COPD patient should immediately prompt a search for coexisting malignancy. Shamroth's window test provides a simple bedside confirmation, assessing for loss of the normal diamond-shaped window when opposing fingernails are placed together. Peripheral cyanosis reflects cold peripheries rather than true systemic hypoxemia, while tar staining offers a visual method to help quantify a patient's smoking pack years. Small muscle wasting in a T1 nerve root distribution is a critical finding, suggesting a Pancoast tumor invading the lower brachial plexus. two specific tremors carry distinct meanings. Asterixis, or flapping tremor, indicates carbon dioxide retention in type 2 respiratory failure, while a fine tremor is a recognized beta-2 agonist medication side effect. Finally, pulse diagnostics reveal pulsus paradoxus, a systolic blood pressure drop greater than 10 millimeters of mercury during inspiration, classic for severe acute asthma and cardiac tamponade, alongside a bounding pulse, which indicates carbon dioxide-mediated vasodilation.
Moving to the face and eyes, several findings carry significant diagnostic weight. Horner syndrome presents as a classic triad of ptosis, meiosis, and anhidrosis, and is directly linked to a Pancoast tumor compressing the cervical sympathetic chain, an essential oncologic neurological correlation. Conjunctival pallor suggests underlying anemia, while facial plethora suggests either polycythemia or superior vena cava obstruction. Central cyanosis, visible specifically in the tongue and oral mucosa, indicates true arterial hypoxemia, distinguishing it from the peripheral cyanosis discussed in the hands. Moving to the neck, a left supraclavicular node, also known as Virchow's node, is a critical indicator of metastatic malignancy and must always be actively sought. Visible use of the sternocleidomastoid and scalene accessory muscles during breathing indicates significant respiratory distress and increased work of breathing. The cricosternal distance, normally 3 to 4 finger breaths, becomes reduced in chronic hyperinflation, offering a useful adjunctive sign of advanced COPD. The single most important alert at this stage of the examination is the combination of a fixed elevated jugular venous pressure together with facial plethora and dilated chest wall collateral veins. This constellation specifically indicates superior vena cava obstruction, a critical oncologic emergency that must never be missed. Understanding mediastinal shift requires grasping a single, elegant mechanical principle, governed by two opposing forces. The push force occurs when space-occupying lesions increase intrathoracic pressure on one side, physically pushing the mediastinum away from that side. The classic causes of this push force are tension pneumothorax and a large pleural effusion, both of which progressively accumulate volume within the pleural space. The pull force occurs in the opposite scenario. Volume-losing lesions create a vacuum-like effect, pulling the mediastinum toward the side of pathology rather than away from it. The classic causes of this pull force are lobar collapse, pulmonary fibrosis, and previous pneumonectomy, all of which reduce the volume of lung tissue on the affected side. Critically, tracheal deviation and apex beat displacement follow these exact same physical rules, since both structures sit within the mobile mediastinum and respond identically to the same pressure imbalances. This means that simply identifying the direction of mediastinal shift, whether the trachea or apex beat has moved away from or toward a particular side, allows you to instantly categorize the underlying pathology as either volume adding or volume losing, dramatically narrowing your differential diagnosis before any further examination is performed. Chest inspection begins with recognizing characteristic chest wall shapes. Barrel chest reflects chronic hyperinflation in COPD and emphysema. Pectus excavatum describes a sunken sternum, while pectus carinatum, or pigeon chest, describes a protruding sternal deformity, both typically benign congenital variants. Kyphoscoliosis, an abnormal spinal curvature, is significant because it can cause restrictive lung disease when severe enough to mechanically limit chest wall expansion. Chest expansion is then assessed by placing both hands on the chest wall, with thumbs meeting in the midline, observing the symmetric separation of the thumbs during a deep breath. Normal expansion exceeds 5 centimeters, and any asymmetry directly localizes pathology such as effusion, pneumothorax, or consolidation to the affected side. A particularly important and specific finding is paradoxical inward abdominal movement during breathing, which strongly suggests diaphragmatic paralysis. Finally, tactile fremitus is assessed by palpating the chest wall while the patient repeats the phrase 99. Fremitus is increased over solid consolidation, since dense tissue transmits vibration efficiently.
but decreased over air in pneumothorax, fluid in effusion, or an obstructed airway in collapse, since all three of these conditions insulate and dampen vibration transmission to the chest wall.
Percussion translates the underlying tissue density of the chest directly into an audible sound, and visualizing this as a single continuous spectrum makes the findings far easier to apply correctly. At one end of the spectrum lies hyperresonance, reflecting high air content, and this is the classic finding in pneumothorax when localized, or in emphysema when generalized throughout both lung fields. Moving along the spectrum, resonant percussion represents normal, healthy, aerated lung tissue, the baseline against which every other finding is compared. Dull percussion reflects increased tissue density from air replacement and is the classic finding in both consolidation and lung collapse. At the extreme far end of the spectrum sits stony dullness, a markedly flat and dense percussion note that represents the absolute hallmark of pleural effusion. An elegant and frequently tested radiological correlation exists here. The characteristic S-shaped contour of stony dullness, which is highest laterally, corresponds precisely to the meniscus sign seen on a chest X-ray in the same patient. One additional pearl worth remembering is that loss of the normal cardiac or liver dullness on percussion indicates an overriding hyperinflated lung, pushing these solid organs out of their expected percussion window. Auscultation begins with distinguishing two fundamentally different breath sound qualities based on their waveform pattern. Vesicular breath sounds show a smooth, soft waveform, with inspiration longer than expiration, and represent the normal sound heard over peripheral lung fields. When vesicular sounds become diminished or absent, this indicates fluid, air, complete airway obstruction, or severe hyperinflation, blocking normal sound transmission to the chest wall. Bronchial breath sounds, by contrast, show a sharper waveform with a distinct gap between inspiration and expiration, and an expiratory phase equal to or longer than inspiration. While entirely normal when heard directly over the central airways, bronchial breath sounds become distinctly pathological when heard over the peripheral lung fields, where their presence strictly indicates consolidation, with patent airways still open beneath the diseased tissue. The underlying mechanism explaining this finding is elegantly simple. Dense, consolidated tissue efficiently transmits the harsher central airway sounds outward to the periphery, sounds that would normally be filtered out and softened by healthy, air-filled lung tissue before ever reaching the stethoscope. Beyond normal breath sounds, 4 categories of adventitious or added sounds carry essential diagnostic meaning. Crackles, also called rales, divide into fine crackles, described as end inspiratory Velcro pops, classic for pulmonary fibrosis and early pulmonary edema, and coarse crackles, heard throughout both inspiration and expiration, classic for pneumonia and bronchiectasis. The single key bedside maneuver here is this. If crackles clear after a cough, the underlying secretions are mobile. If they persist despite coughing, the pathology is fixed, structural disease. Wheeze divides similarly into polyphonic wheeze, indicating diffuse airway narrowing in asthma or COPD, and monophonic wheeze, indicating a focal, fixed obstruction, such as a tumor or foreign body. An absolutely critical and frequently tested concept is the silent chest trap. The absence of wheeze in a patient with known severe asthma does not indicate clinical improvement. It means airflow has become so minimal that no sound can be generated at all, representing a life-threatening situation requiring immediate escalation of care. Stridor is a harsh inspiratory sound indicating upper airway obstruction from croup, epiglottitis, or anaphylaxis, demanding urgent attention. Finally, a pleural rub produces a coarse grating sound that characteristically disappears once a significant pleural effusion develops and physically separates the two inflamed pleural surfaces. Vocal resonance testing exploits the same sound transmission principle as bronchial breath sounds. Bronchophony is tested by having the patient say 99, which becomes unusually loud and clear over consolidated lung tissue. Whispering pectoriloquy takes this further. A whispered 1, 2, 3, normally completely inaudible at the chest wall, becomes distinctly clear over consolidation, making it a highly sensitive sign for this pathology. Egophony involves the patient vocalizing a prolonged E sound, which transmits through consolidated lung as a nasal, bleeding A sound instead, a quality classically likened to a goat. Beyond auscultation, peak expiratory flow rate is compared against either predicted normal values or, more reliably, the patient's own personal best. A severe asthma exacerbation is defined by a peak flow below 50% of predicted or personal best, while a life-threatening exacerbation is defined by a peak flow below 33%, critical cutoffs guiding emergency management decisions. Two important pulse oximetry traps deserve mention. Carbon monoxide poisoning falsely reads as normal oxygenation on standard pulse oximetry, while methemoglobinemia characteristically plateaus around 85% regardless of true oxygen status. Finally, a vital capacity that drops by more than 25% when moving from upright to supine positioning indicates underlying diaphragmatic weakness. Bringing together every examination finding discussed so far, 4 acute respiratory conditions can be clearly distinguished using a single integrated matrix. Lobar pneumonia shows reduced chest expansion, a dull percussion note, increased tactile fremitus, bronchial breath sounds with crackles and egophony, and a centrally positioned trachea. Pleural effusion shows reduced expansion, a stony dull percussion note, decreased fremitus, diminished breath sounds, and a trachea pushed away from the affected side. Pneumothorax shows reduced expansion, a hyperresonant percussion note, decreased fremitus, diminished breath sounds, and similarly, a trachea pushed away from the affected side when under tension. Lobar collapse shows reduced expansion, a dull percussion note, identical to pneumonia, but critically decreased tactile fremitus and a trachea pulled toward the affected side, rather than pushed away. This final comparison between pneumonia and collapse represents one of the most frequently tested discriminating points in the entire respiratory examination. Both conditions produce dullness on percussion, but only tactile fremitus and the direction of tracheal deviation reliably separate them, making this single distinction an essential diagnostic hinge for any clinical vignette presenting with dull percussion and reduced chest expansion. 4 additional chronic and oncologic conditions complete the integrated syndrome matrix. COPD and emphysema present with a barrel chest, generalized hyperresonance, and polyphonic wheeze, but critically, no clubbing. And finding clubbing in this context should immediately prompt a search for an underlying malignancy. Idiopathic pulmonary fibrosis presents with bilaterally reduced chest expansion, fine bibasilar Velcro crackles, and clubbing. This specific pairing of fine basal crackles with clubbing is considered a classic examination pair, frequently appearing together in exam vignettes describing this condition. Bronchiectasis presents with clubbing, coarse crackles that characteristically shift in location after coughing as mobile secretions move within the dilated airways, and a history of significant purulent sputum production. Pancoast tumor presents with ipsilateral Horner syndrome, T1 distribution small hand muscle wasting, and hoarseness resulting from recurrent laryngeal nerve involvement. A single tumor producing 3 distinct, anatomically explainable findings across 3 different body regions. Comparing these 4 conditions side by side, the presence or absence of clubbing becomes a particularly powerful discriminating feature. Its presence in COPD is abnormal and demands investigation, while its presence in pulmonary fibrosis and bronchiectasis is the expected classic finding. Every physical sign discussed throughout this examination converges on a single unifying truth. Physiology dictates pathology, and physical signs in the respiratory examination are never random. 3 underlying forces explain virtually every finding we have covered. Altered anatomy explains structural displacement findings. Pressure dynamics explain tracheal deviation as the direct mechanical result of pressure imbalances between the 2 sides of the chest. Tissue density explains stony dullness, which is simply the physics of percussing fluid rather than air or solid tissue.
And acoustic transmission explains agophony, which is nothing more than the acoustic reality of sound transmission through solid, consolidated tissue compared to normal aerated lung. Every single physical sign in this examination is the inevitable physical consequence of an underlying pathological process, never an arbitrary fact to be memorized in isolation. This is the central exam mindset that should guide your approach to any respiratory examination question. Master the underlying physics and physiology, and the diagnosis will follow logically and automatically, even when you encounter an examination finding or clinical vignette you have never specifically seen before.